My dear students, a very warm welcome to you. We are going to discuss the MCQs on pharmacology. And let's start with the discussion of the pharmacology. Question number 1. Which adverse effect is not common to thiazides and loop diuretics? Hypokalemia, hypocalcemia, hyponatremia, hypochloremia, and alkalosis. Which adverse effect is not common to thiazides and loops? Hypokalemia, hypocalcemia, that's potassium, calcium, sodium, chloride, everything decreased, right? And the last one is alkalosis. Are you thinking about it? Thiazide diuretics and loop diuretics are one of the major diuretics which are used in cardiovascular diseases, right? And what I want to remind you is both of them have got many effects in common. That's what the examiner wants to ask you, which one is not common. So many of them are likely to be common. See, they have to excrete sodium. Naturally, it will be hyponatremia. That has to be there. Potassium will go out. So hypokalemia will be there. And if you're not getting it, then try to remember that because when diuretics are given in heart failure, there's hypokalemia and we have to manage the hypokalemia. So this way you can remember hypokalemia is going to be there. If sodium is going out, chloride has to go out. So chloride will go out. Now if these substances are going out, obviously it's going to be alkalosis. So alkalosis is also out. So what remains is hypocalcemia. And whenever you think about loop and thiazides, always keep in mind a word calcium. And the difference is going to be made about the calcium. Let's go to the answer. Yes, it's hypocalcemia. Loop diuretics produce hypocalcemia and thiazide diuretics, they produce hypercalcemia. Most of the rest of the adverse effects are similar regarding thiazides and loop, and there will be just a change in the severity of the symptoms. Let me remind you some other adverse effects which are important for the diuretics is hearing defects. They are produced by many diuretics. And to add one which you are likely to forget is many of the diuretics have got a sulfonamide structure. And this is why if the patient has sulfa allergy, then the patient could not tolerate the diuretics. So that was question 1. I hope you'll remember. As far as calcium is concerned, the hypocalcemia or hypercalcemia, there's a difference between thiazides and loop. Loop produce hypocalcemia and thiazides produce hypercalcemia. Let's go to the next question. Yeah. Next question. Xylometazoline produces nasal congestion by alpha agonistic action, beta blocking action, beta agonistic action, alpha blocking action, and vasodilation. So the examiner wants to know about the nasal decongestion. And forget about xylometazoline, he wants to know when nasal decongestion will be produced. What's the mechanism of producing nasal decongestion effect? And there's a coining of two receptors with the words blocker and agonist. So alpha agonist, alpha blocker, beta agonist, beta blocker. And the last one is vasodilation. See, this is going to depend on your basic knowledge. Number 1, either you can remember what is xylometazoline, it is from what class, what group. If you come to the conclusion, straightway you get the answer. If not possible, go by logic, you need to know what is decongestion. I have no harm in using layman terminology to make the things more simple. You see, when large number of people will be accommodated in a small room, we always use this word, I am feeling congested. What's the meaning of this? Congestion means accumulation of fluid in a small amount of space. And when this accumulation is going to happen, it can only happen if the blood vessel dilates. Blood vessel dilates, it accommodates more fluid, and this is why you say it's congested. So a simple thing has to be remembered. Can I write it on the board? Yes, this will be important. Vasodilation means congestion. Please remember, put it in your mind, you'll never make a mistake on this. And what's the opposite? The opposite is vasoconstriction. Vasoconstriction means it's going to be decongestion. So the drug in discussion, let's come to the slide. The drug in discussion, xylometazoline, is producing nasal decongestion, means it should produce vasoconstriction. The drug should be able to produce vasoconstriction. And now you get it. If you want to produce constriction of the blood vessels, you have to act on alpha receptor or beta receptor. Predominantly is going to be alpha. So constriction means alpha. You have to stimulate the alpha receptor or block the alpha receptor. If you want to produce constriction, you have to stimulate. So stimulate the alpha receptor, you get vasoconstriction. Constriction means decongestion. All these drugs are ephedrine related drugs. Ephedrine, xylometazoline, oxymetazoline, nafazoline. All of them, they are used as nasal decongestants, and their action is alpha stimulant or alpha agonistic action. Look at the answer. The answer is A, alpha agonistic action. Let's go to the next question. Non-competitive receptor antagonism is exhibited by. I think it should be easy because they are giving the pairs of various drugs. One is agonist, one is antagonist, and you have to choose which one is non-competitive. It is at the receptor, but it's non-competitive. Let's go one by one. Isoprenaline, propranolol. Isoprenaline is a beta stimulant. Propranolol is a beta blocker. So it's acting on the same receptor. Noradrenaline, phenoxybenzamine. Noradrenaline is alpha stimulant. Phenoxybenzamine is alpha blocker. Then histamine, epinephrine. Are the receptors same? No. Histamine acts on histaminergic receptors. Epinephrine acts on adrenergic receptors. So this is not receptor antagonism. So this is out. I'll remind you. This is called physiological antagonism. Next is iron and dysperioxamine. Are there any receptors for iron? No. Iron is a chemical. And dysperioxamine is used in case of iron poisoning because it chelates the iron. So that's called chemical antagonism. Next one is morphine, naloxone. And morphine acts on opioid receptor. Naloxone blocks the receptor. So that's again receptor antagonism. So what we are left out with are isoprenaline, propranolol, noradrenaline, phenoxybenzamine, and morphine, naloxone. These three are receptor antagonisms. Now out of these three, we have to remember which one is non-competitive. Which one is non-competitive. So if you remember your beta blockers, we always say beta blockers competitively block the beta receptor. It means this antagonism is reversible. It can be reversed when you go on adding an agonist. Similarly, if you think the case of morphine poisoning can be reversed by using naloxone. So these two are reversible types of antagonism. It means there is a competition, fair competition at the same receptor and same site. So isoprenaline, propranolol, morphine, naloxone are out, and we are left with norepinephrine and phenoxybenzamine. Always remember, this is a rare example. This is non-competitive receptor antagonism. Please remember this, you don't have much examples of non-competitive receptor antagonism. So have a look at the answer. Non-competitive antagonism, noradrenaline, phenoxybenzamine. Okay, next question. Which of the following is an antidote for overdose of heparin? Which of the following is an antidote for overdose of heparin? So they are asking you the management of heparin overdose, heparin toxicity. Vitamin K, folinic acid, warfarin, protamine sulfate, and penicillamine are the options. If you think of the anticoagulants, heparin is an anticoagulant which is used parenterally. Warfarin is used by oral route of administration. And if you remember, warfarin is a vitamin K antagonist. So vitamin K doesn't apply for heparin. Folinic acid is totally from a different chapter. Next, warfarin is an anticoagulant itself, so it cannot be used. Then you are left with protamine sulfate and penicillamine. If you remember your pharmacology, penicillamine is a drug which is used for the heavy metal poisoning. And this is why this is out. You are left with protamine sulfate. And if you go to our modules of pharmacology, we revised all these antidotes on general pharmacology. We also discussed them in blood. Iron, dysperioxamine, heparin, protamine sulfate, and warfarin, vitamin K. So the answer is protamine sulfate. We move on to the next question. That's question number 5. Who blocks inactivated sodium channels in partially depolarized Purkinje fibers? You can solve it very easily because first thing, who is sodium channel blocker? Look at the options. Lidocaine, amiodarone, propranolol, verapamil, and ebutylide. If you have a look at this, you don't have to go up to B, C, D, E. The first one, lidocaine, is a sodium channel blocker. And just screen the drugs, rest of the drugs. Is there any sodium channel blocker? Amiodarone, class 3. Propranolol is a beta blocker. Verapamil is class 4. Ibutyllite, same. You are not getting any sodium channel blocker. So you know lidocaine produces the blockade of the inactivated sodium channels, especially in partially depolarized and the damaged fibers. So especially after myocardial infarction. So the answer is lidocaine. Have a look on the slide I have written. Amiodarone is class 3, propranolol is class 2, verapamil class 4, and ibutyllite class 3. This was question number 5. And now I take you to the next question. The next question is, which test is essential in a young lady needing oral anticoagulation with warfarin? Which test is essential in a young lady needing oral anticoagulation with warfarin? Options are serum cholesterol, bone density scan, pregnancy test, serum bilirubin, and blood urea nitrogen. So if you think about warfarin sodium, whenever you think about warfarin, this is something which you don't have to forget. You always have to remember. Warfarin is an oral anticoagulant, and this is one of the candidates which is teratogenic. And in addition, it can produce bleeding in the fetus. So these two things you can never forget. If your basic is clear and if you know this, you'll immediately pick up option number C. That's pregnancy test. If you don't have the knowledge of this, if you don't know about this, then you'll keep on thinking which adverse effect warfarin produces. So does it do anything to cholesterol and bone density scan? And okay, now you go logically. I'll take these 4 names and I'll take the 5th name, and you just sense it how that particular investigation is different from all other investigations. Number 1 is cholesterol. You're trying to find out what substance is abnormal inside the body. Then bone density scan. Again, you're going inside the body and having a look at your bones. Next, you go to serum bilirubin. Again, you take out something, find out what is bilirubin. Blood urea nitrogen. Same, you're finding out what is the blood urea nitrogen. And look at pregnancy test. Don't you feel it's a totally different kind of investigation? It's investigating something else. And this way also, probably you can come to the answer. Let's go to the answer, pregnancy test. And let's have a bit of knowledge about the other adverse effects of the anticoagulants. The other adverse effect of warfarin is alopecia, number 1. And second one is dermatitis. So none of the tests could be related to this. As far as heparin is concerned, heparin produces osteoporosis. So you need to remember that because that bone density scan came, I would like to remind you, heparin produces osteoporosis. These are oral anticoagulants. The most common adverse effect will be bleeding. But after bleeding, you got to remember 2 or 3 things. So for heparin, remember osteoporosis. And for warfarin, remember alopecia dermatitis. And don't forget the teratogenicity with the oral anticoagulants. That's warfarin. Let's go to the next question. Yeah. Which vitamin is most necessary in the treatment of alcohol addiction? I hope you know alcoholism depletes number of nutrients inside the body. Let's have a look at the option. Pyridoxine, folic acid, thiamine, ascorbic acid, and cyanocobalamin. Pyridoxine is vitamin B6. As soon as we say about pyridoxine and pyridoxine depletion, do you remember anything? If you don't remember, I'll remind you. That's an anti-tuberculosis drug, INH, isoniazid. So, whenever it's pyridoxine, think about isoniazid. And if the question is about isoniazid, then search for pyridoxine. Alcohol, there may be pyridoxine deficiency, but that's not specific. Next, folic acid. Yes, it can produce folic acid deficiency. It can produce thiamine deficiency, ascorbic acid, and cyanocobalamin. But we are not speaking about a pregnant woman and the folic acid deficiency and some defects or anything. We are speaking about chronic alcohol addiction. And what's the manifestation final in chronic alcohol addiction is the central nervous system affection leading to what is called Wernicke's encephalopathy and Korsakoff psychosis. And these two things are related to thiamine. That's vitamin B1. Let's go to the answer. Vitamin B1 deficiency, Wernicke encephalopathy and Korsakoff psychosis. So that's thiamine. Thiamine is extremely useful in the management of chronic alcohol addiction. it can be life-saving for this patient as far as preventing of the manifestations are concerned. Let's go to next question. That's question 8. For better effect, most of the statins are administered at night, except, first understand the stem. If you want to have a better effect, the statement is most of the statins are given at night, and it's asking you which statin is not given at night, or it's not necessary to give it at night. So obviously out of the 5, 4 must be given at night, and it's only one which cannot be given at night. Think about the statins. They are HMG CoA reductase inhibitor, and I'm showing you the most logical way to think about the question to come to a right conclusion. You need to know that HMG CoA reductase activity is highest at night. So if the enzyme is active, you can inhibit it. If it's not much active, what inhibition you are going to produce? So because the enzyme is active at night, it's better if your blood levels are good for that particular drug at night. And which drug is going to produce good blood levels at night, even at night, is even if you take the drug in the morning, if its effect is continued, if it's got long half-life, then it will be able to give you the same kind of blood levels even at night. If the drug is short-acting, it's not going to give this blood level at night. Naturally, what you need to do is you have to pick up a drug from these drugs which is long-acting. Now I'll tell you a simple way to solve this. You see, when the statins came, the most popular and the best tolerated, commonly used statin was atorvastatin. And amongst all then came simvastatin, lovastatin, etc. And last came rosuvastatin. Rosuvastatin is the newest. Okay. And so I'm putting it as atorvastatin is oldest, the first one, the beginner in this group. Rosuvastatin is the last one. And surprisingly, both of them have got long half-life. And only the middle ones who came in between, they have got a short half-life. So answer for this question can be either atorvastatin or rosuvastatin, because these are long-acting agents. Now atorvastatin is not there in these options. Naturally you go for rosuvastatin, but some other examiner can remove rosuvastatin from here, and then answer could be atorvastatin in that case. Let's have a look at the answer. Rosuvastatin, just for your revision, HMG CoA reductase activity is highest at night. So you need to use a drug with long T half. Now the answer here is rosuva. In addition, I have written down also atorvastatin. I hope it's quite clear and it's interesting. For your patient, you will have to give the drug in such a way that good blood levels are there at night. You can give atorvastatin, rosuvastatin, patient can take it in the morning, still it will give you good blood levels. If you have to use anything out of the rest of the 4, simva, lova, prava, fluva, you need to give it more frequently, and your last dose has to be there at bedtime so that you can get good levels at night. Go to the next question. Ritodrin is predominantly used as a vasodilator, bronchodilator, tocolytic, nasal decongestant, and vasopressor. Before discussing the question, I'll tell you a secret to succeed in pharmacology. What is most important is when someone asks you a question and you start thinking about a drug, you first need to identify this drug is in which class, it is in which chapter. If you could remember, if you could locate the chapter, your 50% of the job is done. And this is why I'm suggesting you something. Have a special notebook for pharmacology classifications and start writing the classifications. Simple way to do is to read the classification, close your textbook, look up, keep on roaming around and try to memorize. Come back, take a piece of paper and try to write how much you could remember. If you could remember only 2 groups, it's okay. Again open the book, again read, close the book, and on a blank paper try to write it again and make up your classification, and finally write it in your special notebook. You will never make a mistake. You'll easily pick up the drug is from which class. So that's the way to solve this multiple choice question, because you need to know what is ritodrin. If you don't know this, you can't do anything. Ritodrin, if you have heard it, this is most commonly used to prevent the premature labor. This is very commonly used. Now if you ask me It is from which class? You learnt it in autonomic nervous system, and there is selective beta agonist. For example, salbutamol, terbutaline, isoethylene, salmeterol, formoterol, and ritotrine. So it is here. Can it dilate the bronchus? Yes, it can dilate the bronchus because there is beta 2 receptor. So the action, the most common effect. Okay, do you see something concerned with uterus and the options? Vasodilator, bronchodilator, tocolytic, nasal decongestant, vasopressor. Obviously, what option is speaking about uterus is tocolytic. So ritotrine is a tocolytic. And the question, see, there's a small twist in the question. It's not asking what is ritotrine. It's asking ritotrine is predominantly used as, because it is a bronchodilator, but it's used predominantly as a tocolytic agent. Let's go to the answer. Understand the word tocolytic. Tokos means childbirth, and this is why tocolytic is something which is going to prevent the contraction of uterus, is going to relax the uterus. So is uterine relaxant. So when there is premature labor, you can give ritotrine and postpone this premature labor or prevent this premature labor. It's a selective beta 2 agonist, beta 2 stimulant, because when you stimulate the beta 2 receptors, you get relaxation, you get dilation. So all other options, they are out of question here. We go to the next question. Is apixaban acts by binding to? Again, it's a similar question, and if you look at the options, probably you can come to know that something is happening about platelets, because there is ADP receptor, thromboxane A2 synthetase, plasminogen, glycoprotein 2B3A receptor, and plasmin. So apixaban, yes, it does act on the platelets. There are three types of antiplatelet drugs. Number one, aspirin, which acts by affecting the mechanism of thromboxane A2. That's one. Second group is drugs which combine with the ADP receptor and inhibit ADP receptor binding. You have ticlopidine and clopidogrel. And one more receptor which is important, especially for the fibrinogen to start its effect, is glycoprotein 2B3A receptor, GP2B3A receptor. And we go one by one. ADP receptor is ticlopidine and clopidogrel. Thromboxane A2 will be low dose aspirin, and the examiner has put plasminogen and plasmin. You can straightway remove them out. They are concerned with the thrombolysis. So plasminogen, plasmin, both are in the same variety, so they'll be out. You are left with glycoprotein 2B3A receptor and apixaban. When the spelling is ending with mab, it's a monoclonal antibody. Mab, monoclonal antibody. Apixaban is a monoclonal antibody to glycoprotein 2B3A receptor. Look at the answer. Answer is GP2B3A receptor. ADP binding is inhibited by clopidogrel and ticlopidine, and thromboxane A2 affection is done by aspirin. These are two other groups, and the group which is asked on this question is GP2B3A receptor antagonist. One is apixaban, and you also have in this group tirofiban and eptifibatide. So we could revise the three mechanisms of antiplatelet action. I think you enjoyed this session and you got to learn many things. Thank you very much for listening. All the best.